we are here right now with Dr. Jonathan Tarbox, and with all this new insurance reform and more people having access, thank goodness, to ABA through their insurance, it's raised some questions in a lot of people's minds about how are we going to make sure that the level of ABA therapy is quality and appropriate, and who's going to determine this, and what's going to happen. And you are here to share with us some new recommendations that have come out. So who put this together, first of all? Let's start there.
So the Behavior Analyst Certification Board, or the BACB, is the credentialing board that offers the BCBA certification.
Okay. So the board certified behavior analysts, and they have to, we've talked before on the show about the fact that they have to go through a lot of education and hours and
you have to take
test.
You have to have a master's degree in a related field to ABA, but it could be, special education, things like that. And you have to take 5 master's level courses covering various aspects of ABA and ethics. And then you have to do basically a year or a year and a half long internship or practicum hours underneath someone else who's already a BCBA. After you get all that done, then you take an examination, and if you pass the exam, then you're certified as a behavior analyst.
And the board that governs this and gives out the licenses, they've sat down, the certification, excuse me, they've sat down and said, here are our recommendations for what we think quality ABA is going to look like, what it's going to
for children with ASD. Exactly. Yeah, and so they put together the BACB put together a task force of experts who have decades of experience in treating autism, and they basically put and then they sought out recommendations from a lot more experts, and they put together basically one set of recommendations that's targeted for insurance companies and for parents and for providers to some extent too. So it's very useful. It'll take a minute, but if you read through it, I think you will actually find the vast majority of it very consumable. It's very straightforward. Most of it is written in good, practical, everyday language. And
is it available to us widely?
Absolutely, yeah. So to download it, you go to BACB.com, and there's a link to it on the homepage. It'll say news, and it'll say practice recommendations for autism, something like that. And just download it for free. It's a PDF. It's about 50 pages or so.
And we've said on the show over and over and over again about how this is a whole new set of circumstances. Everybody's starting out kind of level playing field, that we all don't know enough, but we have to get educated in this about what the criteria is going to be, because it's going to make a difference of how you start ABA, how long ABA happens, when your child is done with ABA. We need to educate ourselves.
That's right. And there's so many different, because ABA is a general science of learning and motivation, it can be applied to pretty much everything. And so that is true for kids with autism as well. So, you could use ABA to teach a child, to cut his toenails or something, versus you could use ABA 30 to 40 hours a week for 4 years with a young child with autism to try to teach them everything they need to know to catch up to the typical development. So there's a huge range of what ABA can be applied to. And so because of all of that, there's a lot of confusion still. And some providers only provide services for about 10 hours a week. So if that's the case, what are they doing exactly? And how is a parent or an insurance company supposed to know what is that kind of treatment versus a more comprehensive program? And how many hours a week are appropriate for different ages, and who should be supervising, how many kids can one BCBA supervise? Lots of questions about details of how to actually do it and what it looks like that are really unanswered. Folks who've been doing it for a long time, like at CARD, we know, and so there's nothing new in here for us really, but it's great to see, like if we had written it, this is essentially what it would look like. So we're really excited to see it.
So you're excited
Yeah, we're really excited about it. It's great.
Well, that's thrilling. And I think as a parent, a lot of times people will write in and say, we were with an ABA provider for a year or 2, and we finally got to the point where we were fed up and we switched to another ABA provider, and we realized how much time we wasted in those 2 years.
That's scary.
And how are we supposed to know what's good ABA and what isn't good ABA? I mean, even in my community, and I had the benefit of CARD, and there, at a time, as I said earlier, when people got funding for different ABA providers, and so there was my son having ABA, and there was another child that I was aware of within our circle of friends that was starting ABA with a different provider. And I remember about 6 months in, she said, mom said, today was a really bad day. My child was just being really, really difficult, to the point where the therapist said, well, that's it, I just can't work with him today, and left. And I was like, what? What? I mean, the child is going to learn then, if I'm difficult enough, you will go away.
Of course, yeah.
like, this is a person who should know that you can't do that.
If
And I was
anyone should know,
appalled.
yeah.
I was appalled.
There's a huge degree of variability in terms of quality out there. It's really scary.
Yeah,
Even somewhere like
scary.
here in Southern California, where we have probably the highest concentration of great ABA providers, but even here, there's a huge degree of variation in quality. And a lot of the details that really affect quality and outcomes that aren't necessarily specified by anyone previously are described pretty well here. I mean, this isn't going to cover every single thing you need to know, but it gives you a good basic structure of what it should look like.
And it's free. We can download
That's
it.
right.
Fabulous. Okay, so let's take it in little increments, like everything we do.
Sure.
Tell us a little bit about some salient points that we need to be aware of.
Okay, so on page, it has several different sections, and on page 11 is a section that outlines essential practice elements of ABA. So these are basic features that no matter what provider you go to, no matter what your child's situation is, if they're a child with ASD getting ABA treatment, you should see most or all of these basic elements in place. So let's just run through them real quick.
Good.
Some of them are going to be pretty obvious. Some of them might be talked about less. First key element is description of specific levels of behavior at baseline. So when your kid first comes in, the provider needs to do an assessment of all of their skills, all of their challenging behaviors, and give you a clear picture with data of what your child's current status is. It's not, a lot of sort of lower quality providers will come in and just sort of do their cookie cutter cookbook approach to, every kid has the same program, regardless of their current level of functioning, which is just contrary to the whole philosophy of ABA. It's crazy.
And that's a hard meeting, by the way, when you see how far your child is behind, but it's an important meeting.
That's right, absolutely.
You got to hear it once, and then you can get into the progress.
That's right. And when each new teaching lesson is introduced, the provider does that again. I mean, they do a brief probe. Maybe it only takes a minute, but they do a brief probe of does this kid already have this skill? And they do an assessment of baseline performance to make sure you're not wasting the kid's time by teaching them stuff they already know.
Absolutely.
All right, number 2, a practical focus on establishing small units of behavior which build towards larger, more significant changes in functioning related to improved health and levels of independence. So establishing small units of behavior. So this is how we always talk about baby steps in ABA, right? You don't start out by trying to teach the whole alphabet. You start by teaching one letter, right? And not even just every way you could talk about one letter, but maybe just matching letters, right? And that's never an end in itself. That's always with the goal of combining all of these different behaviors into larger, more functional skills.
Right. Okay.
Number 3, collection, quantification, and analysis of direct observational data. So if you're doing ABA, you got to collect some data, and different providers have slightly different ways of doing that, and that's okay. And there is some evidence to suggest that maybe you can take data only on the first trial of each target on every given day, but you got to collect some data. So man, if you see, if you have a kid on the spectrum getting ABA therapy and your ABA therapist says, well, we don't want to waste time on data collection, they don't know what they're talking about. Period.
In families, you see people carrying around these books, these binders
there's
that
no way
collect
around
the data.
And there's a simple reason why, because human memory isn't good enough. It just isn't. And that goes for everything we do,
Yeah, absolutely. Okay.
I mean, just try going shopping without a list and see if your memory is good enough, let alone teaching a child everything he needs to know to catch up to typical development. Are you kidding me?
Absolutely. And to know if what you're doing is working.
Right. And you have 5 different therapists working with the child and a supervisor, and the parents have input and everything that you're supposed to just remember. It's impossible.
It's not effective. It's not efficient.
Exactly. Number 4, an emphasis on understanding the current function and future value of behaviors targeted for treatment. So that means understanding why a kid is doing what they're doing, right? And and understanding why you would expect them to do what you want them to do in the future. So man, if you're teaching a skill, there better be a function for that skill in the child's future life.
Right.
So if you're teaching letters, there better be an opportunity for the kid to read or to point out letters or talk about letters in the future. If there isn't, what are you doing wasting the kid's time?
Absolutely.
Okay.
And a lot of these are common sense, and you would think, okay, well, this should be in every program because it should. And why do we have to say it? But it is important to define things so that you have a guideline to see.
And frankly, every time that you think about, talk about, or look at your kid's program, you could just take this little checklist and just make a check mark there. If it's there, fine, done. You don't have to think about it again. But I'll bet frequently you'll find that at least 1 or 2 of these things is being neglected. And in some bad quality programs, I'll bet half of these are being neglected.
Okay, frightening.
Okay, and you just cut me off whenever we need to go.
No, you're doing fine.
Number 5, efforts to design, establish, and manage the treatment environments in order to minimize problem behaviors and maximize rate of reinforcement. So an emphasis on controlling the treatment environment. So it's not just chaos, it's not just craziness. And the purpose of doing this is to decrease challenging behaviors and provide lots of opportunities for reinforcement. Okay.
And you know what's striking to me about this, and correct me if I'm wrong in this, but if these guidelines are adopted and if insurance companies start to follow them, it empowers us as consumers.
Absolutely.
Because at some point, somebody, if it hasn't happened already, I'm sure it's already happened, that somebody, the insurance company assigns you a provider and they come and they start doing, and you see that these things aren't here, you're going to have to petition to get a different provider.
Absolutely.
And to be able to show they're not doing these things is how you're going to get it done.
That's exactly right. And insurance companies don't want to pay for bad quality therapy. They're not going to do it. So if it's the case that, your provider is not doing these things, they're not going to pay that provider. You're going to get a different provider.
Right. There we go. Okay. That's why we need to know this stuff.
Number 6, use of carefully constructed, individualized, and detailed behavior analytic treatment plan, which utilizes reinforcement and other behavior analytic principles as opposed to the use of methods or techniques which lack consensus about their effectiveness based on evidence and peer-reviewed publications. So that's kind of a mouthful, but what it's saying is your child's treatment plan should be individualized and should be detailed, and it should be based on procedures that have been proven to work. So if your child's supervisor has a hunch about a new way to do something, that's fine. They should test it out with data and see if it works. But the first step should always be to do something that we already know works, because it's worked for thousands of kids previously.
Right. I always like to say my kid's not a petri dish.
Right, exactly. All right, number 7, an emphasis on ongoing and frequent direct assessment, analysis, and adjustments to the treatment plan. I mean, I cannot emphasize this enough. Probably 99% of the bad quality ABA programs that I've observed lack that. They lack careful, thoughtful, and analytic assessment of child progress on an ongoing basis.
Yeah.
So you got the supervisor coming in and looking at the kid's program saying, yeah, it looks like he's doing pretty good. Let's keep going for a couple more weeks and see what happens. No. Every single teaching lesson in the child's program is like an experiment where you're saying, does this intervention work for this child, right? And if it doesn't, you need to do something different. It's not good enough to just try for a while, right?
Yeah,
That's the whole point of data collection, and graphing the data is for careful analysis and supervision.
Right, and I think this is a really important point, because a lot of us were told before we started ABA that our children just couldn't do certain things because they had autism. But in truth, if our child is having ABA and we're not seeing progress, one of the variables needs to be shifted in some direction, some way, somehow. We don't keep beating our head against the same wall saying, we're doing it this way and eventually they're going to get it. That's not this song.
That's right. And just a basic rule is kids learn stuff in ABA programs. Kids learn stuff in ABA programs, period. It doesn't matter how affected your child is, they are going to learn something. There is a huge amount of variability in response to treatment, so some kids are going to learn super fast. Some kids it's going to be more challenging, but you will see progress. If you're not seeing progress, it's not a good ABA program, period.
And I love about you guys that you behaviorists, that you say, and if they're not, kids learn in ABA programs, and if they're not, it's not the kid's fault.
It's not the kid. Yeah, absolutely.
Love that. Okay.
Okay, number 8, use of treatment protocols that are implemented repeatedly, frequently, and consistently across environments until the client can function independently in multiple situations. So this idea of the need for consistency, and consistency across environments, consistency across caregivers, across therapists is really, really crucial. You know what
this one reads to me? If they're not going to the birthday parties with you, they're not getting it completely done. That's what I read in the parentheses.
I love it.
They have to go different places. You have to. This has to work in the grocery store while I'm going through the aisle.
Absolutely.
And so if you're just doing it around the kitchen table and getting a great result, that's wonderful. But it has to work out in the real world.
Right. Exactly. And so I'll contrast, the opposite of this is the type of sort of drop-in or pull-out services that you'll see where your kid gets 1 hour a week of you name it, whatever other therapy, and that's it. And then there's no attempt to even see outside of that 1 hour a week whether or not gains are actually being made, right? And so you can name whatever therapy you want in that 1 hour a week. There's a lot of them. ABA is the opposite of that. We don't, and that's partially why we don't do 1 hour a week, because it's not enough. We do a lot more than, but also we're looking for generalization outside of those treatment sessions.
Right. Okay.
And if we don't get that, we're not doing our job. That's not an afterthought. That is the goal of treatment.
Okay.
Okay. Number 9, direct support and training of family members and or other involved professionals, okay? So parent involvement is really key. And if you don't have that, again, you're not doing your job as a behavior analyst.
Right.
The parents have to be involved, or whoever it is, the guardians, the grandparents, whoever it is that's part of the child family unit and family system needs to be involved in treatment from the very beginning.
Absolutely. And that's a wonderful thing for us. I know a lot of parents get into this, and there's big controversy right now about some organizations that are saying, oh, the parents should be doing this. But this is saying that the parents need to learn along with. And that
they need to be involved in professionally delivered therapy, not take the place of. Right. The parents are not doing the treatment. The parents are being involved in the treatment.
And this is great for us because it means that the babysitter comes over and you get some help and support, that grandma comes to visit, and there's, they're helping grandma to know how to be able to accomplish the same tasks you want. This is a plus.
Exactly. Number 10, and I think this is the last bit on these recommendations. Supervision and management by a behavior analyst with expertise and formal training in ABA for the treatment of ASD. So what that means is not just anybody can supervise these programs. You need to be an expert in supervising ABA programs for kids with autism. Okay,
Right.
If you don't have that expertise and that training in particular, you're not qualified to do it.
Okay.
Now, ideally, that's someone with a BCBA. And more we're getting to that where all the master's level folks who are expert clinicians have a BCBA. We're getting closer to that.
Right.
I would say today, no, not everybody needs to have a BCBA, because I know plenty of amazing clinicians that just haven't taken the test yet, or got some other different kind of degree, or maybe they're a licensed psychologist. But more and more we're moving towards these folks should be board certified behavior analysts, and frankly, medical insurance requires it. So that's just a given now.
What about the other professionals in the field of mental health who feel that they're qualified?
Well, yeah. So what really matters is your actual training and expertise, not what letters are next to your name, right?
Okay.
And the BCBA certification ensures at least a minimum level of training and expertise, because it shows that you took those classes, you had some supervised experience, and you passed the test. However, there are plenty of other. I have friends that are, let's say, licensed social workers, licensed marriage and family therapists who have been doing this for 15 years and are absolute champs. And I would be happy for them to supervise my kids' treatment. You know what I mean? So yeah, they can do it too. However, more and more, honestly, they're not even going to be able to bill for funding anymore if they don't get the BCBA. So even all of these folks who are just champs are still going and just take the 5 classes, get the experience, take the test. It's not that hard.
And which brings home that this is a recommendation. Insurance companies have not yet adopted this. This just came out recently.
This just came out, and the purpose of this is to help inform what insurance companies will do. However, each insurance company is allowed to make their own, or does make their own policy handbooks. They have to comply with law, state law, but they're allowed to make their own policies. This is not law. This is just recommendations by the BACB, and this is not specific to any state. The BACB is an international organization.
Right. So perhaps at some point we can, an insurance company maybe as a marketing tool can say, and we have adopted these principles recommended by this organization.
No insurance company will ever do that, but they might never. They will never do that because they will always reserve the right to make their own policies and their own handbooks, which is true. I mean, they do have the right to do that.
However,
but as
parents,
hopefully,
we should know these things.
And you should push for this. Yeah, you should say, I want something like this, and hopefully their response will be, yeah, we based our policy on this.
All right, good to know. We're going to take a break and come back and talk about some of the other things, other reasons why you definitely want to read this and inform yourself. Stick with us. Welcome back to Autism Live. We're here with Dr. Jonathan Tarbox. You are the head of research and development here at the Center for Autism and Related Disorders and the executive director of the Autism Research Group.
Correct.
And we have been talking about recommendations that have recently come out for standards of care, basically. What constitutes evidence-based and medically necessary treatment for children with autism spectrum disorders. Okay, and this is really helpful to parents. This is information that we can get for free, that we can download, and really use it as a tool to determine whether the ABA that we're receiving in our homes is what it should be.
Absolutely. And frankly, Well, first of all, I'd recommend every single parent of a child with autism should download this and read this. Okay. Even if you're not getting ABA with your child, download this and read this. This is going to teach you a lot about what ABA is.
Fabulous.
And it may well show you some of the things that you actually might want to have for your child.
Okay, and tell us again where we can get this for free.
BACB.com.
Okay.
Download it from their homepage, and it's free. It's a PDF that you download, print it out, save it, read it on your iPhone, whatever.
Okay, great. So we talked a little bit about, things that the program has to have. What's the next component of this?
Okay, so the next component that they outline is a general description of sort of two different categories of overall models of treatment. So like I was saying in our earlier segment, ABA can be, applied to a million different things, to any scale you can think of, from teaching one teeny little skill all the way up to 3 years of teaching everything a kid needs to know. And so there's a lot of questions about, well, how much ABA is the right amount, or how many skills should we be targeting, and for what age, et cetera. And so the BACB adopted a model that we've been promoting also, which is a distinction between comprehensive, comprehensive ABA treatment versus targeted or focused ABA treatment.
Okay, great.
Okay? So it's not this black and white. It's there's a lot of probably categories in between, but this is at least one way to sort of conceptualize it that makes sense and is useful. It does. So comprehensive basically means you address everything. Targeted means there's specific goals, and you work on those until that's done. Okay. Okay, so let's go through some of the specifics that they give. Okay, so focused ABA. Focused ABA involves direct service delivery to the client. It's not restricted by age, cognitive level, or co-occurring conditions. And focused ABA refers to treatment provided directly to the client for a limited number of behavioral targets. So let me give you an example. If a child comes through our door and is not potty trained, has a significant amount of challenging behavior, and has no real functional communication at all, the parent might say, help. I need to get rid of these problem behaviors. I need him potty trained, and I need him to at least be able to tell me when he wants something, right? Without having a tantrum. So then what we might put together is a treatment plan that targets those specific 3 areas, and that's the purpose of this child's ABA treatment, is to deal with those 3 areas, and we're going to keep doing it until we fix those 3 areas, or until we meet the goals that we've prescribed for those 3 areas, and then after that, the kid's done. Okay. Notice that I didn't say anything about the age of the person. Right. I did say kid, but actually when you think about it, it could be an adult. It could be a 60-year-old. I've worked with 60-year-olds. Right. So it doesn't matter what age. It doesn't matter what other conditions they have. So they could certainly have intellectual disability or CP or you name it, any other disabilities. Right. And it doesn't matter what setting they live in. So this could be in the home, it could be in the school, it could be maybe the kid's living in a group home or an institution, or you name it. Right. But the idea is targeted, short-term, fix these problems. When we're done with these problems, we're done. Okay. And I would imagine the flip of that is true, too, because a lot of times we have people write in and they assume that because they have older, high-functioning kids, that ABA is closed off to them because it has to be this thing where you're 40 hours a week and their child's going to school and doesn't need that, and they think that ABA is ridiculous. Exactly. But this could be for them as well, that if your child is just having social issues that you would like to target. Thank you for pointing that out, because oftentimes people think of targeted or focused intervention as just sort of putting out fires for emergencies, like, oh my God, self-injurious behavior or aggression. But you're exactly right. It can be targeted to just specific social skills. So my child's doing great, lots of language, wants to make friends. It seems like the other kids want to be friends with my child, but he has no perspective-taking ability at all. What do I do about this? Well, we can put together a targeted intervention just to teach a wide range of perspective-taking skills. So we make some goals, maybe 5 or 10 perspective-taking goals. We're going to work on these goals with the kid until the kid's done with those goals. Right. And that's that. For the kid who's doing so great, there were at least 2 people that wrote in this summer and talked about kids that were getting ready to go off to college and saying, where can I go to teach my very high-functioning kid who intellectually is ready for college, but emotionally and just the idea of riding the bus and looking at the signs and knowing what to do when flexibility, when situations, how do I trust that my child's really ready and not go with them? So these kinds of things could address that. That's right. You could absolutely put together a treatment plan that addresses sort of college readiness skills or transition skills, independent living skills, any of those things. So really wonderful, that we can look at it
in this way. But then there are other people that it's the flip, that that have kids that they want the full bore.
Right, and so that's the comprehensive. Oh, and by the way, real quick, for focused ABA, there's literally hundreds of studies showing that this works for children and adolescents and even adults with autism. Hundreds of studies supporting this method of treatment.
Okay,
now,
I think it's so important that parents know that that's an option.
Absolutely. And comprehensive ABA treatment, on the other hand, is sort of the flip, and the goal here is to address essentially every skill deficit and every behavior problem that a person is experiencing at any given time.
Right.
And so the classic thing that we think of, and the approach that has the most research behind it in terms of comprehensive services, is young children with autism. So starting as early as possible, starting at, let's say, 3.5 or 4 or 5 at the latest, or younger, and continuing for 30 to 40 hours a week and for 2 to 4 years, okay? Or, you know, if they're completely done earlier, that's fine, but with most kids, it could take 2 to 4 years. The goal of comprehensive,
5 for us.
well, yeah, absolutely.
That's 5 for us.
The goal of comprehensive ABA is to catch the child up. This is the basic idea, is teach the maximum you can in the amount of time that you have them.
Right.
Because the funding's gonna run out, you know, the
Right.
kid is going to get older. So the goal is teach as much as you can. For some children who experience this type of treatment, they're going to recover from autism. And that's the word that we use to describe the fact that there are no more clinically significant skill deficits anymore. We just don't have anything left to teach. So they're done with us because they've graduated. There's literally nothing left to teach. Most kids still aren't going to have that outcome, but even kids that aren't going to recover are going to learn a lot.
Yeah.
And the goal with them is to maximize their skill development across every area of human functioning so that they can function as independently as possible.
Now, first question that I have, because so many people write in and feel like they missed the boat because they wanted this for their kids, but now their child is 6, or their child is 8, or their child is 12.
Right.
What do you say to those families? Like, is there still a possibility of doing a comprehensive ABA program with a 10-year-old?
There's no research on comprehensive ABA programs for kids who are school age or older. It just hasn't been done yet.
Okay.
The oldest study was done by, the study with the oldest kids in comprehensive ABA was done by Sven Eikeseth and colleagues in Norway. Got some great behavior analysts out in Norway. And what they did was they studied 30 hours a week of ABA for 2.5 years, and the kids were between the ages of 4 and 7 at intake. Okay. So a little bit older. It's not early intervention anymore, but it's not, adolescence by any means.
Right.
Between 4 and 7 at intake, that means they were between 6.5 and 9.5 when they were done.
Right.
Okay. And that study showed very strong effects and showed very clearly that comprehensive ABA can have very large treatment effects for that group. And they compared it to another group of kids that were getting just sort of eclectic special education for the same number of hours and the same level of intensity, all 1-to-1, and a huge difference in outcome. Okay. So comprehensive ABA has been proven to work for kids between 4 and 7 at intake.
Okay.
But for the older, I didn't really answer your question for the older kids, right?
Well, but you did, because you said the research isn't there.
Right.
And my thing, because you're the executive director of the Autism Research Group, and one of the things that you are always asking parents is, what would you like some more research on? And I want to encourage everybody who's watching, who's asked those questions, write in to the Autism Research Group if you want that kind of study to be done, because I'm assuming that that's really what it takes, is enough people saying this is important enough.
Well, it's going to be really challenging, because the problem with doing research on comprehensive ABA treatment is it's incredibly costly. So, to get 30 or 40 hours a week of treatment, depending on a lot of different variables, it could cost upwards of $60,000 to $100,000 a year for one kid. And to have a big enough group of kids to where you can actually have a group design where you have a treatment group and a control group, you might need 20 or 30 kids all getting that. And then you need it for maybe 2 or 3 years. So do the math. It ends up being extraordinarily expensive. So who's going to pay for that? Right now, essentially no one will pay, well, that's not true, not nobody, but very few people will pay for that much ABA treatment for older kids in research. So
are we going to see then with the insurance that when people have older children and they get ABA, that the insurance company is going to say that 10 hours they're not going to go for the comprehensive?
We don't know. We don't know yet. And actually what the BACB recommends is that the choice between comprehensive and focused intervention be made not on the basis of age, but on the basis of the clinical priorities for the individual and the goals that are necessary for each individual. So for example, we could have a 12-year-old kid whose aggression is so severe that it puts people in danger, and 40 hours a week may well be justified for that child, even if he had no other real significant deficits, right? So 40 hours a week, yes, absolutely, just in order to control the aggression so he doesn't hurt himself or other people. You know, so it totally depends on the individual child. For younger kids, the prescription is clear: 30 to 40 hours a week for 2 or more years. Period. It doesn't even matter what the goals are.
But it's clear because the research showed that it was effective.
Because the research shows, yeah. So for older kids, they're not taking a stance. The BCAB is not taking a stance on the specific number of hours, and quite frankly, there isn't any research basis for taking a stance on the number of hours. You need to customize each individual child's treatment plan based on their unique needs and how clinically significant their impairment is. Okay.
All right. Well, there's room there for people on an individual basis.
Yeah.
But clearly, somebody needs to get that study done.
Yeah, we're working on it.
Okay, all right. Because I'm looking at you. I got nobody else to look at, so I'm looking at you. I hear that it needs backing, but maybe that's the thing that we all need to put some time and energy into as parents, because we know that we drive this bus. How loud we yell, when we yell, and what we say at least drives part of the bus.
I will say I was in Minnesota yesterday visiting a center called the Minnesota Autism Center, which is a great ABA provider up there in the Minneapolis area. They've got multiple centers and schools, and they're actually implementing skills now. They're a really fantastic outfit, and they serve many kids in the slightly older range, and they are doing up to 30, 40 hours a week sometimes with these kids, and they're seeing great results. And so I've actually been talking to them about potentially publishing some of those data. But again, it's a huge project. But yeah, people are doing it, and it does work. And quite frankly, I mean, the thing is, we know from an ABA perspective and even a common sense perspective that the more time you spend learning something, the faster you're going to learn it, right? If you want to get good at anything, what do? Practice it a lot. So if you're 10, 12 years old, if you want to maximize that kid's skill development, 30 hours is going to be better than 20, 40 is going to be better than 30. So. Yeah,
I just want to send the message home to parents, though, that, because a lot of them feel disheartened and I missed that boat. That don't decide not to do ABA in any way. Go for the progress. Focus on what you can get. Go for the progress, and we'll keep plugging on that. But
and if you want to maximize your child's skill development, the status of the scientific research on autism treatment today is entirely clear. ABA is your best bet to make your child's skills develop the most and the fastest in the short amount of time you have to work on it.
Okay.
So yeah, it doesn't matter what age your child is. If there's something he needs to learn, ABA procedures can teach him to do that.
Okay. We're running out of time. So just in terms of an overview, what are some of the other things? I noticed when you went down the list earlier, one of the things was that there is a recommendation in here about when it's time to stop therapy, when the child is done. Because I know a lot of us have questions about how is the insurance company going to decide at what point. Even for us, we went through the regional center and had funding, and it was always the question. I always felt like I was left out of that discussion about when the regional center was going to decide to end funding, and I would always pound on the table and say, here's what we need. And
the honest answer, the no BS answer is funding providers are going to end treatment as soon as they can because they don't have enough funding.
Right.
So their motivation, of course they want to help the kids, yes.
Absolutely.
And when I say funding providers, I'm talking about regional centers, school district, insurance companies, you name it. They don't have enough funding to treat all of the kids that they need to fund treatment for, and so they are going to end the child's treatment as soon as they can kind of get away with it, and there's a lot of variation. There's certainly some funding providers that they're going to stick with it until it really truly is clinically okay to let go. But I'm sorry, there's a lot of funding providers that are not. They're going to quit funding as soon as they can, as soon as they can do it without the parents getting too upset, essentially.
But there's a criteria in here that sets up guidelines for when it's appropriate clinically?
Well, they have guidelines for the process of determining this. There's no hard and fast, criteria for when services should be terminated. That's going to be different for every individual child. But yeah, they do, if I can just get to it.
And I'm sorry,
here.
I sprung that on you.
No problem.
Because we're so towards the end, and there's so much information in here about setting how many hours is appropriate, as I'm seeing as you're flipping through. But again, we can't state often enough how important it is that we educate ourselves and take advantage of this document that's free. And it's going to help us to know what's appropriate.
And so here's some basic guidelines they give for discharging. So how do you know when it's appropriate to discharge a client from ABA therapy? And here's the basic guidelines they give. So first of all, when the client has achieved the treatment goals. So if you're doing a focused intervention, and again, let's say it's teaching perspective taking skills, and you make 10 different goals of perspective taking, including generalization of those skills to everyday peer interactions. When you've documented, the kid can do all of that now, you're done.
Right.
No reason to stick around any longer. You might want to do some transition planning and maybe a little bit of follow-up consultation to make sure, so you can ensure maintenance. But you've achieved the goals that you set.
Okay.
The next one is the client no longer meets the diagnostic criteria for ASD. So that's for the recovery kids who, and that's nice to see this in writing from the BACB. They're not using the word recovery, but that's what they're talking about here.
They don't fit it anywhere.
They don't, they can't be diagnosed as having autism anymore. So for the recovery kids, that's also very clear. And gosh darn it, it's obvious when we recover a kid, we don't want him to stick around anymore. I mean, we'll miss him and it's sad, but we're so happy to see him go. It's graduation day.
Yeah, absolutely.
Number 3, the client does not demonstrate progress towards goals for successive authorization periods. So this is an important one.
It is an important one.
And I say that kids learn in ABA programs, period. That is true. Every kid's going to have a different rate of progress. Kids don't necessarily learn in bad quality ABA programs, okay? So if your provider is doing a bad job with your child, you might not see any progress. It could be functionally equivalent to babysitting. I've seen that before. Thankfully not very often, but it does occur. So this criterion here is put in there to guard against that. And of course, we don't even need to worry about that. Medical insurance companies are going to be worrying about that. If we're not able to demonstrate progress, they're not going to fund anymore. Yeah,
that's exactly what I'm hearing, is that as a parent, you need to make sure, you need to keep drilling to make sure that the progress is happening, or you're going to lose your funding source.
That's right. And it's also possible in some cases, if the goals were set by someone who's not very good at setting goals that are individualized and appropriate, that the goals that were set are unreasonable. So for example, there are some kids who are not going to develop vocal speech, and so if that's one of the goals and you've achieved everything else and you've been working with the kid for years and you're not working on some other kind of non-vocal communication system, that would be pretty stupid, first of all. But if you're showing look, he's not making vocal speech, and 3 months go by, we assess it, no progress. Another 3 months, no progress. Another 3 months, and we've tried every single thing that's been proven to work to develop vocal speech, then at some point, maybe 6 months, 12 months, 18 months, it is maybe appropriate to say, maybe we're not going to make so much progress in that.
Okay. This is all really wonderful, and I want to thank you so much. As we're finishing up talking, I'm going to ask Emily to play some of the different ways that you can get in touch with us during the weekend, because we'd love for the conversation to continue. You can always ask questions of any expert that we've had here on the show, and we know that Dr. Tarbox comes in every week on Friday, but we also know where to get a hold of him if it's something that needs to be addressed before the following Friday. Thank you so much for coming in and sharing this with us.
Every parent, go to BACB.com.
I'm going to get it today.
Download.
I'm going to get it today, and we'll continue to talk about this from time to time in the coming weeks and months and see what happens with insurance.